Dear Chairman, ladies and gentlemen, good afternoon. I'm very happy to be here for the first time, and I would like to special thanks to the organization committee for inviting me to this beautiful event. My topic is neonatology, and I will try to present the postnatal follow-up the newborns with kidney and urinary tract anomalies from a neonatologist perspective in point of view in light of long-term complications. Here is my presentation plan, but I am aware that the majority in the hall are obstetricians, therefore don't worry, I will try not to overwhelm you with boring pediatric details. I will draw a general perspective without sharing the secrets of intensive care regarding on neonatal care of CACUT. You know, CACUT is not a single disease. It covers a broad spectrum of developmental disorders affecting the kidney and the urinary tract. The incidence is estimated that 0.3 to 1.6 in 1,000 births. They are often diagnosed during routine prenatal ultrasound and constitutes approximately 20 to 30% of all anomalies identified in the prenatal period. And there is high accuracy between the prenatal diagnosis and the final postnatal diagnosis. They have a wide range of clinical presentations from mild and transient conditions such as mild urinary tract dilatation to those responsible for early death such as bilateral renal agenesis. CACUT contributes significantly to the burden of chronic kidney disease and is responsible for almost half of all pediatric chronic end-stage renal disease are estimated to be due to CACUT. Because of its close relationship, chronic kidney disease, our priority should be to protect the nephrons to preserve the kidney functions, so it's important to provide timely intervention. Congenital kidney malformations are categorized based on changes in kidney size, shape, number, or location, and also it's important to consider the maldevelopment of collecting system as well as the kidneys. It's important to understand how CACUT shapes the course of chronic kidney disease. You know, chronic kidney disease refers irreversible kidney damage that can further progress to end-stage renal disease. Maternal, fetal, and early neonatal environment contribute to chronic adult disorders, and late gestation is late gestation is critical for nephron endowment. Thank you. And being a premature or a low birth weight infant is associated with a lower number of nephrons, and reduced number nephron leads to hyperfiltration and glomerular hypertension and proteinuria, which perpetuates nephron loss, glomerulosclerosis, and finally chronic kidney disease. This is the hyperfiltration injury. In children, causes of chronic kidney disease are very different from those in adults. Here are some epidemiological studies were conducted in Europe, Australia, USA, and Japan. CACUT has been determined the most common cause for chronic kidney disease. In developing countries, the importance of CACUT in the chronic kidney disease etiology is not different. Here's another research from low middle-income countries, and CACUT was reported as the underlying etiology almost half of the patients with chronic kidney disease. So how is the progression to chronic kidney disease? It's variable and depends on the progression factors. First, non-modifiable progression factors. I also mentioned Kekut and low birth weight, and modifiable progression factors second. It means there are parameters that we can intervene these patients, and follow-up principle of these patients are also based on this issue, and hypertension and the proteinuria are the most important independent risk factors in both children and adult ages. The importance of achievement of blood control, blood pressure targets, and decreasing proteinuria are well emphasized in the ESCAPE trial. The ESCAPE study group showed that received blood pressure control under the 5th percentile slows the pediatric chronic kidney disease progression during 5 years follow-up. And what are the early predictive factors that will show the progression to kidney failure and replacement therapy in infants with severe congenital anomalies of the kidney and the urinary tract? In this multi-center study, 12 pediatric nephrology centers in Japan submitted data, and the result of this study demonstrated that bilateral kidney lesions, oligohydramnios, neonatal complications, acute kidney injury or infections, or ventilator use and inotrope use are related with kidney failure and end-stage renal disease. Similarly, in a birth cohort of infants with severe Kekut, further kidney damage was predicted by neonatal kidney functions. And according to the results of this study, gestational age was significantly similar in patients who had early progressed to the end-stage renal disease. And comorbidities included pulmonary hypoplasia, and inotrope use, also important predictors, and neonatal serum biomarkers, nadir serum creatinine and statin C are the most significant biomarkers for progression to end-stage renal disease. So, management of newborns, of infants with severe Kekut should consider prolonging the lifespan of individual kidney function. Patients with bilateral and severe Kekut may have significant renal and respiratory compromise at birth and require systemic management, including respiratory support, nutritional support, fluid balance, acid-base status balance, and finally, if necessary, renal replacement therapies starting from an early age. For newborns with end-stage renal disease, dialysis is generally considered a bridging step until kidney transplantation is possible. And survival has improved significantly in recent decades in line with the advancement in dialysis technology and, of course, clinical expertise. This is one of the most extensive studies on renal replacement therapies in the neonatal period and its outcomes. You see, the most common condition required renal replacement therapies during the neonatal period constitute Kekut, and the most preferred renal replacement therapy, peritoneal dialysis. And as per current international recommendation, this is the first-line renal replacement therapy. And the 2-year survival after the onset of renal replacement therapies is about 80%, and the most common cause for death is infections. And finally, good news about Kekut. In this study, in which 10,000 patients with renal replacement were evaluated, Kekut patients seems to be more lucky in graft survival after renal transplant compared to the non-Kekut group. And now, follow-up about the Kekut patients. Unilateral renal agenesis. The management is based on detecting other kidney, evaluating for non-renal anomalies, and the evidence of kidney injury. So first, an initial ultrasonography. You know, ultrasonography is typically the first test performed in these patients. Confirmed or suspected CACUT. Conditions which have unilateral involvement do not need immediate attention, so renal ultrasonography should be delayed for 48 hours after birth to avoid underestimating the severity of findings due to typical newborn physiologic dehydration. But in patients with bilateral anomalies or severe perinatal findings, or in case of suspicious lower urinary tract obstruction, or in case of anuria, imaging and if necessary interventions will occur soon after birth. After the ultrasonography, avoiding cystogram is recommended because of association with vesicoureteral reflux. And all individuals with solitary kidney are at risk for compensatory hypertrophy, so serial renal ultrasonography is recommended. And blood pressure, urine analysis, and kidney functions should be monitored for the possible hyperfiltration injury. Determining the compensatory growth by measuring kidney length can potentially represent an advantage in the nephron endowment in the neonatal period and reduce the risk of glomerular filtration rate decreases by age. So, a congenital solitary kidney with increased renal length at birth has a greater nephron number and therefore a greater renal functional reserve and better prognosis than those without renal hyperplasia at birth. In other words, the lack of compensatory hypertrophy can point subsequent development of chronic kidney disease. And it's recommended to increase the frequency of follow-up in the presence of accompanying ipsilateral CACUT or detecting renal damage in the patient. So what await us when we encounter patients with bilateral renal agenesis? Once it was thought to be fatal due to severe olgohydroamniasis, Potter secans, and concomitant pulmonary hyperplasia and renal failure. Hence, there was also ethical concerns about fetal interventions. But recently, studies are underway to assess the impacts of amnioinfusions on lung development and its outcomes. Although neonatal morbidity and mortality still remain high, there is a shift towards favorable results with the increase of fetal interventions and advanced neonatal care. And bilateral renal agenesis, it's critical to note that even if lung development is adequate, morbidity and mortality remain high. And the neonate will have at risk both end-stage renal disease and preterm birth and its complications. Multicystic kidney disease. Bilateral lesions can cause Potter secans and with early death from pulmonary hyperplasia because hyperplasia, and unilateral ones tend to involute over time with the compensatory hypertrophy of the contralateral kidney and the absence of this compensatory growth, then hypodysplasia we must consider. Patients with simple multicystic dysplastic kidneys generally have normal or near normal kidney functions, but patients with complex multicystic dysplastic kidneys, bilateral or unilateral with contralateral anomalies show evidence of renal impairment. Sorry. In addition to confirming the diagnosis, the initial ultrasonography can screen for accompanying vesicoureteral reflux, contralateral kidney anomalies, and genital anomalies. And it's important making annual surveillance in this patient, including blood pressure, urine analysis, serum creatinine, because of the progression of chronic kidney disease. Routine voiding cystoscopy cannot be recommended in these patients except in complex type or the presence of a febrile urinary tract infections. In the past, nephrectomy of the multicystic dysplastic vertebrae was often performed due to the perceived risk for malignancy, but however, data now recommends conservative watch and wait strategy because the rate of vein tumor or other malignancies is very low, so routine nephrectomy is no longer indicated. If I talk on about prognosis in prenatally diagnosed multicystic dysplastic kidneys, bilateral lesions, anhidroamniosis, prenatal contralateral renal anomalies, and prenatal extrarenal anomalies were significantly associated with adverse neonatal outcomes and death. Then, according to results of this study, in the absence of significant associated findings, unilateral multicystic dysplastic kidney have a benign neonatal course. The term solitary functioning kidney includes heterogeneous conditions with different pathogenesis, and renal agenesis is different than unilateral multicystic dysplastic kidneys. I want to emphasize this point too. Look, outcomes of children with unilateral renal agenesis may differ from those with multicystic dysplastic kidney, and the results of this study also support this. Unilateral renal anomalies had more non-renal anomalies, had more associated KECOT, and hypertension, proteinuria, and composite outcomes were worse in these patients. Ectopic kidney and horseshoe kidney, a postnatal ultrasound is recommended to confirm the exact location and evaluation for other urological abnormalities. Voiding is recommended to rule out WUR, and long-term sequelae include chronic kidney disease secondary to long-standing compensatory glomerular filtration, so annual kidney functions, urine analysis, and blood pressure monitoring are warranted in these patients. And now, urinary tract dilatation. You know, previously it's known as hydronephrosis. In 2014, a multidisciplinary consensus group was established, unified urinary tract dilatation definitions and classification system. It's the most common congenital condition identified on prenatal ultrasonography. It can be physiological or pathological. The most common type is physiological urinary tract dilatation, and pathological urinary tract dilatation is often associated with congenital anomalies of the kidneys, bladders, ureters, and the urethra, and the pathologic ones can be life-threatening and may require fetal intervention or early postnatal intervention. The ultimate goal in urinary tract dilatation evaluation is to detect anomalies. Thus, we will likely have significant urological abnormality and therefore benefit from early detection and intervention. And the degree of the urinary tract dilatation correlates with an increased risk of significant pathology. Therefore, lower degrees of dilatation are more likely to reflect physiological urinary tract than higher degrees of urinary tract dilatation. Here is the classification. The postnatal classification system includes 3 categories each. By threshold of anteroposterior renal pelvic diameter and ultrasound features. At low risk, if anteroposterior renal pelvis diameter between 10 and 14 millimeters is low risk and ultrasonography is normal. And in the presence of abnormal peripheric thickness and appearance with bladder abnormalities and pelvic diameter greater than 15 millimeters, intermediate risk, and abnormal ultrasonography and pelvic diameter greater than 15 millimeters, high risk urinary tract dilatation. And in low risk group, follow-up ultrasonography is recommended 1 to 6 months. For those with intermediate risk group, it's recommended in 1 to 3 months, and high risk group monthly. And further assessment with voiding cystoscopy and prescription of prophylactic antibiotics should remain at the discretion of the clinician and depending on the underlying diagnosis, because of the optimal management strategy is controversial. For those with high-risk group, follow-up ultrasonography at 1 month and voiding and prophylactic antibiotics are all recommended, and functional scan is discretion of clinician. And prognosis. Prognosis range from spontaneous resolution to progressive end-stage renal disease, and in patients with unilateral dilatation, if the contralateral kidney is normal, the overall long-term renal function is good. But detection of a urinary tract obstruction of vesicoureteral reflux, the presence of oligohydramnios or renal cortical abnormalities, anomalies of the contralateral kidney, recurrent infections, and detection at a low gestational age are all independently associated risk factors with poor postnatal renal functions. And vesicoureteral reflux. Vesicoureteral reflux is the retrograde flow of urine from the bladder into the upper urinary tract during the bladder contraction. And voiding cystography is the gold standard for diagnosis and evaluation. It's classified as grade 1 to through 5, and it's based on how far the urine backups and how wide the ureter is, with grade 1 and grade 5. Grade 1 is the least severe one, and grade 5 is the most severe one. And each kidneys may have different degrees of vesicoureteral reflux. Most reflux, grade 1 and 2 reflux, will resolve spontaneously, and approximately half of the grade 3 cases and lower percentage of higher grades will also resolve spontaneously. So, neonates with vesicoureteral reflux should be followed by annual testing with voiding. And the physicians should maintain a high index suspicion for urinary tract infections and check a urine culture with each fever attack until it resolves. And posterior ureteral valve. They are the most common cause of lower urinary tract obstructions. Prolonged in utero obstruction results in varying degrees of renal dysplasia, oligohydramniosis, and pulmonary hypoplasia, and it is one of the most common causes of chronic kidney disease in boys. In boys in the neonatal period. Management: first, ultrasonography and voiding cystoureterography, catheterization of the bladder to relieve the obstruction, and stabilization of electrolytes and fluid status, and endoscopic valve ablation and vesicostomy if needed. Prognosis is poor, with 20 to 60 of patients progressing to end-stage renal disease by the second decade of life. Predictors of poor outcome include prematurity, low birth weight, fetal bladder diameter, and the initial creatinine greater than 1. Because of renal dysplasia and recurrent urinary tract infections are also poor prognostic factors. But even after endoscopic resection of the valves, patients are candidates for end-stage renal disease. Look at this study. In this study, newborns who needed intervention for urinary tract decompression within the first week of their lives, half of the patients developed significant end-stage renal disease in childhood. And invasive ventilation in newborn period, nadir creatinine level, surgical urinary diversion, and invasive ventilation they were associated with worse outcomes. And what about patients who received fetal interventions? This is a retrospective single-centered cohort study of 60 male infants who survived the fetal interventions. Of course, this is not a complete comparison, the prior study, but I think it can give an idea in terms of vesicoamniotic chance. 62% of patients have progressed to chronic kidney disease within the first year of their lives. And as shown, only gestational age, less than 35 weeks, was a significant predictor of advanced chronic kidney disease, and biomarkers, looking at the biomarkers, peak serum creatinine levels, discharge creatinine levels, and cystatin C levels were predictive biomarkers. Uretero-pelvic junction option, they are self-limiting mild ones, self-limiting and do not require any intervention, but form severe degrees of obstruction, diverting the urinary flow through a nephrostomy tube, will protect the kidney further injury, and if surgery is required, as in the case 20 or 25 of children with uretero-pelvic junction obstruction, pyeloplasty is performed. And ureterovesical obstruction or obstructed megaureter, synonyms they are, urinary stasis can occur, and recurrent urinary tract infections and loss of renal function can all occur. But up to 70 to 80 of megaureters resolve spontaneously. Prophylactic antibiotics may be considered, and in cases which do not resolve or recurrent infections and renal scarring, surgical options include endoscopic repair or open surgery. And ureteral cells, vesicoureteral reflux is present, half of them. So first, urinary ultrasonography and voiding cystoscopy. If surgery needed, endoscopy or open reconstruction, but prognosis after surgery in these patients is good. And key points: congenital anomalies of the kidneys and urinary tract are common. It's important to identify patients who require emergency postnatal evaluation. Neonates may require additional monitoring depending on the degree of anomalies, fatal interventions that could potentially alter perinatal survival, and children with K could require long-term follow-up for chronic kidney disease. Shukran.